after first stage revision, we have to find whether patient is ready for new implant, that is the second stage revision. No disclosures. Now, two-stage revision is the standard procedure in PGI. When to perform the second stage, this is debatable. Issues are reliable indicators which will say that second stage revision is possible now. Risk factors and proper timing. So I'll be delving into these three issues. Reliable indicators. So intraoperatively, frozen section is taken, and then serum sera, CRP, and ESR. These are the three reliable indicators. There are other inflammatory markers, but these are the. Now CRP and ESR, they are used to reassess control of infection, inflammation of tissues before second stage is taken. And intraoperatively, when second stage revision is being done, so minimum 3 periprosthetic frozen sections should be taken, and they are sent for histopathology. And till we wait for the report, we do not proceed. 3 tissue cultures minimum after removal of spacers, and Fieldman criteria is used for frozen section, that is more than 5 neutrophils per high power field. Should be there at least 5 different microscopic fields. So depending on that, if it is less than, if it is fitting into Fieldman criteria, then we do the implantation of the new prosthesis. Otherwise, if it is more than 5 neutrophils per high power field, then we use another spacer after debridement. Of course, debridement is done in second stage also. And what is taken as a failure, that is repeated spacer implantation is done. And recurrent infection is there with the same pathogen after new prosthesis. So next is reliable indicators. So intraoperatively frozen section, that is the most useful indicator with a sensitivity of 90% and a specificity of 83. CRP and ESR are useful in ruling in infection. That is, specificity is 88% and 84% respectively. But they are poor, they have poor utility in ruling out infection with sensitivity of 40% and 50%. So this is the ROC curve showing the sensitivity and specificity of all the 3 indicators. If you see the intra-op frozen section, that has got a specificity and sensitivity of more than 83%. Now next is risk factors for failed 2-stage revision. The positive frozen section, that is failure rate, it shows failure rate of second stage revision to the extent of 4.2 times. And atypical pathogens infection, the failure rate increases by 8.8 times. Previous sinus tract is there, and we do 2-stage revision, chance the failure rate increased by almost 8%, 8 times. What are the not risk factors for failure? Antibiotic treatment less than 6 weeks and positive CRP and ESR. These are not taken as risk factors for failure. Timing of reimplantation. So patient is asymptomatic clinically, no systemic features, no sinus, no discharge. CRP, ESR, that is in the decreasing trend or normal, and the length of antibiotic should be minimum of 6 weeks. That is sufficient. Other inflammatory markers, as joint aspiration is usually not possible in many cases. So synovial white cell count and leukocyte strip, that is difficult to do. Spacer detention time. Now, 12 to 16 weeks of spacer detention time is a valuable point for reimplantation with success rate of more than 92%. If we keep the spacer for more than 16 weeks, over retention of the spacer, that may increase the chances of failure to the extent of 18%. What we follow, two-stage revision usually with cemented processes. Antibiotic is used in antibiotic-laden cement of spacer, and systemic treatment is chosen on the basis of culture sensitivity, earlier culture sensitivity. So antibiotic, same as antibiotic is used. 2 to 3 weeks of IV antibiotics. Reimplantation is performed minimum of 6 weeks, spacer interval. And we use stem with distal fixation in both tibia and as well as femur. So this is a case of loosening with infective TKR. So in second stage revision, this is the X-rays with the distal and the tibial as well as femur fixed with the stem and the semi-constrained, that is LCCK was used. So what is successful treatment in PJI? Delphi-based consensus definition is infection eradication, healed wounds without any fistula, drainage or sinus, no infection recurrence by same organism strain, no subsequent surgical intervention for infection after reimplantation surgery, and no occurrence of PGI-related mortality. To conclude, intraoperative frozen section is a good indicator at time of revision surgery. CRP, ESR, they have got poor diagnostic value. Atypical pathogen infection, positive frozen section and previous sinus, they are high risk factors for failure of second stage revision. Antibiotic treatment less than 6 weeks would not increase failure rate. Spacer detention time usually should be 12 to 16 weeks, which had a higher success rate rather than more than 16 weeks of spacer detention. Proper timing of reimplantation should be combined with disappearance of clinical symptoms and negative intraoperative frozen sections. Thank you very much for patient listening.